Good afternoon, and welcome to Leading with Care in a Technological Age. My name is Jane Phillpot, and I'm proud to be your moderator for this event. I'm the Dean of the Faculty of Health Sciences here at Queen's University. And you are joining us today to hear 3 of 28 authors of the groundbreaking book, Without Compassion, There Is No Healthcare. It's published by McGill Queen's University Press. And the speakers today are going to be talking about the challenges that are threatening the healthcare systems of today and tomorrow, and whether humans can ensure that healthcare remains compassionate in an era of emerging and disruptive technologies. Today's event is brought to you by AMS Healthcare. AMS Healthcare is here to advance the Canadian healthcare system through innovation and technology while remaining rooted in compassion and our medical history. They convene networks, develop leaders, and fund crucial activities in medical history, healthcare research, education, and clinical practice. Their work helps to improve healthcare for all Canadians. I'm joining you today from Kingston, Ontario, and I want to acknowledge the people that have lived on these lands for millennia. The area around here has been home to the Haudenosaunee and to the Anishinaabe peoples for thousands of years. We know that the land was exchanged as part of the Crawford Purchase in the late 18th century, even though no written treaty exists. Many other Indigenous peoples lived on this land at different times, including the Huron-Wendat and the Métis people. And I want to acknowledge and thank those who have cared for the land and now share it with us. Before I introduce our panelists, a couple of housekeeping notes. We're going to be live tweeting this event, and the hashtag will be Without Compassion. That's right, hashtag Without Compassion, because without compassion, there is no healthcare. So we're also going to leave as much time as we can in the hour for Q&A. And so please start at any point putting questions into the chat, and our guests will be addressing as many of those as we can manage before we wrap things up at 1:30 p.m. Eastern Time. We have 3 fabulous panelists today, and I'll tell you a little bit about each of them. Gillian Strudwick is the interim chief nursing executive and a scientist at the Center for Addictions and Mental Health. She's also an assistant professor at the Institute for Health Policy, Management and Evaluation at the University of Toronto. Her research lies at the intersection of mental health, technology, and digital compassion. And she is a proud 2018 AMS Phoenix Fellow. Our second guest is Tina Martimianakis. She's a 2017 AMS Phoenix Fellow, an associate professor and scientist at the Department of Pediatrics and the Wilson Center at the University of Toronto. Her research and leadership is directed towards supporting compassionate organizational transformation, improving the patient experience, and addressing conditions that impact wellness and success of clinical faculty and learners. And finally, we'll be hearing from Brian Hodges, who is the Executive Vice President, Education, and the Chief Medical Officer at the University Health Network, and Professor in the Temerity Faculty of Medicine at the University of Toronto. Brian is a practicing psychiatrist and teacher. His research and writing focus on assessment, competence, and compassion also includes work on the future of the health professions. And you might be surprised to know, for a psychiatrist, that Brian has just finished his 7th of 7 days on the COVID ward. So there's somebody that's putting his talk into action. And in fact, we're going to turn to Brian first, who's going to introduce to us this book and its subject matter. Over to you, Brian.
Thank you, Jane, very much. Such a great pleasure to join you. It's true, I just came down from the ward, and these are such extraordinary times for all of us, and a real chance to reevaluate so many things. And I want to explain a little bit of the origin of the book and some of its purposes today. And then my colleagues, Tina and Gillian, will tell you a little more detail about two of the very interesting dimensions in the book. And then I think, Jane, we're going to have some discussion, which is great. The origin of the book, you heard about the AMS, and AMS healthcare has for 90 years more been concerned with the state of healthcare. And I would say a decade ago, at that time, the board of the AMS became concerned that healthcare was very focused on quality, which is wonderful, and very focused on efficiency, which is essential, very focused on many aspects, but it seemed that compassion, caring was falling out of the frame. And the challenge from the board and the Phoenix project that was generated from it was to try to re-examine and bring back a focus on compassion. Interestingly, this coincided with some very dramatic advances in technology, the arrival of artificial intelligence, the new forms of care that accelerated unbelievably in the last year. Virtual was on our radar when we started thinking about the book, but wow. In my hospital in UHN, we have about 1 million ambulatory visits a year, and in 3 weeks, 80% of them became virtual. So we've lived through an extraordinary transformation, and all of this stresses technology in important ways. But I want to just frame a few things for you that are anchors for you to access the book. And thank you if you've already looked at it or read it or shared it, and I hope you will continue to do so. The first is, what do we really mean by compassion? And compassion is a concept that means many things to many people, and we didn't enforce a strict definition. That would be inappropriate, but the book does two things. The first is it understands what empathy is, empathy being my ability or your ability to understand how someone else feels, sometimes described as putting yourself in their shoes, that empathy is not enough. It's only empathy if it only goes as far as understanding. That compassion requires something more. Compassion is an act. Compassion is a desire to do something to reduce suffering. So the book is about compassion, not only empathy. That becomes very important in many of the chapters in the book when we start to realize we all have only a partial understanding of the world. We only have partial perspectives. To give an example of a wonderful chapter not represented by our group today, but there's a chapter on equity and diversity. And those authors remind us that each of our experiences is unique, but we can never understand exactly what everyone else would experience. So to be truly compassionate, we have to think very broadly. So the book grapples with compassion for sure, and many of the chapters in the book look at compassion at different levels, whether that's at the individual level, the institutional level, the country level, the national level. Also, what is technology? I think sometimes in technology we think Edison, light bulbs, silicon, wires, but there's a lot of technologies. And technology is almost always a way for human beings to amplify or extend something that they do. I happen to have very funny, chubby little fingers, and I can't pick up a grain of rice. So I'm grateful for chopsticks or a fork. Those are technologies. This technology, oh, I'm in the funny background screen. This is my hair. If I put it on my face, you'll see it. This is a technology that has been amazingly important to all of us in the last little while. But when you put this technology on, you need this technology. Because if you want to form a human relationship we're used to since birth, face to face. And that brings us to the technology we're on right now, which is Zoom. Now you hear about Zoom fatigue. Zoom on its own is simply a way of broadcasting faces and voices. Is it empathic? Is it compassionate? It depends how you use it. The purpose and function of the book is to talk about how we continue to provide healthcare, how we continue to do what healthcare is for, which is to care for people, to reduce suffering, and work with technology, identifying when technology will extend our compassion. Gillian will talk to you about digital compassion. Sometimes technology can extend human compassion, and sometimes it interferes. The last metaphor I'd leave you quickly would be just this one. So I'm drinking this right now. This is not an ad, if you see it here. This looks like food and it tastes like food. But if you tried to live on it, you would die. It's not food. And I would say that some of the technologies, Zoom included, sometimes look like a human relationship and feel like a human relationship, but they may be missing critical ingredients that are necessary for us to thrive. So the book also calls out a really critical look for us at each technology we adopt, whether it's just picking up an iPad, or whether you're on the board of a hospital buying an electronic patient record, or whether you're in the community adopting an AI technology, to ask yourself, is that technology extending and augmenting the human ability to care? That's what the book is about. Jane, turn it back to you.
Thanks very much, Brian. And I really appreciated your metaphors. I do hope that nobody tries to live on Diet Coke. It will barely get you through the day, let alone to get through beyond that. But excellent. So I am fascinated. You tell us that Gillian's going to talk to us about digital compassion, and I'm really interested in that, Gillian, and what you've been writing and studying, and particularly about its impact on providers and patients as well as their caregivers. So tell us what you've been thinking on this.
Sure. And so I thought I'd take a couple of minutes to talk about what is this concept of digital compassion after all, because it certainly was a new concept for me not that long ago. And I imagine it's a new concept for many of you here on the Zoom platform. And so many of us are familiar and maybe comfortable with the understanding of what compassion means. And that's something that Brian just shared with us, the definition. And so in the chapter that I wrote with two of my colleagues, Dr. David Wilger and Dr. Allison Crawford, we refer to a five-part definition of compassion that's commonly used. In that there are 5 parts. So there's one, the awareness of another's experience of suffering or need, which Brian spoke about. The idea of feeling moved, appraising one's own social roles within the context of suffering. The 4th part about making judgments about the person who is suffering and the situational context. And then the 5th part being what really, I think, differentiates it from empathy. And it's this idea of feeling driven to help. And so what I described are essentially the distinct components that give us a hint as to what an emotional responsive compassion might be, or how it may be translated into action. But when we bring in digital technologies to understand what compassion is, we have to consider how digital technologies may actually mediate some of those components of compassionate care. And so this is all very good for me to talk about it at a conceptual level, but perhaps I give you an example from my own practice to see what it really feels or could look like. And so I'll go backwards in time to a pre-pandemic time when I was working as an inpatient mental health nurse here at the Center for Addiction and Mental Health in Toronto. And I was caring for a man who had lost his housing since he had been admitted to our inpatient unit, our inpatient mental health unit, I should say. And he was looking for housing in what is a very expensive city, in different neighborhoods that he had not been to. And for whatever reason it is, he wasn't able to leave the unit to actually go physically to these apartments and have a look at them. And so I remember him being quite concerned about making sure that he had access to things like the pharmacy, transit, green space, and all of these sorts of resources that had shaped good and bad experiences of where he'd lived in the past. And so we had to think creatively. He couldn't leave. But we wanted to be able to have him get to these neighborhoods and have a look at and walk around. And so we did a virtual walking tour, got our laptop out, went to Google Earth, and then did virtual walking tours to see where's the bus stop, where's the library, where are some of the resources that would be required for him to feel like this is the neighborhood that he wants to live in. And so this example speaks to something that Brian spoke about. So this is about how the technology enabled a compassionate interaction that could not have occurred without it. So it's not about the technology per se, it's the fact that it was allow us to have this interesting experience. And what I also thought was very interesting was how this simple use of technology, acted as a catalyst for a deeper conversation. So, which was important to me as a mental health nurse, and being able to establish this very important therapeutic relationship that was genuine, but also support his recovery journey in a holistic way that was supported with regards to what was important to him. And so my sense is that if each and every one of us on this call were to reflect on a digital experience that we've had in the last year, especially since the start of the pandemic, because many of our healthcare experiences have in fact been digital experiences, we can start to identify which ones have had elements of compassionate care present. We certainly know when we don't feel that there's been compassionate care present. But when there is digital compassion present, it can be hard to identify what was it that made it compassionate, I should say. How did it come to be? And so that's why this definition of digital compassion is evolving and emerging as we learn more about what it is and as we gain more experience in this. And this needs to happen at a patient level, at a caregiver level, at a provider level, at an organizational level, and beyond, as you'll read about it in the book. And what I think is interesting about the book is the questions and ideas that it begins to wrestle with regards to compassion, of course, and what it looks like and how it comes to be in our technological world. So I'll leave it at that.
Thanks very much, Gillian. I'm sure that you've inspired a number of questions. And as I've been listening to you, I'm thinking about it being National Nursing Week. So happy Nurses Week to you and your colleagues. Nursing has always been the bedrock of compassion. And so we salute all nurses this week. And thinking about digital compassion just, makes me think about the ways that nurses have been a part of the expression of digital compassion. So I know that people are going to have a lot of questions for you. So I hope they're already putting them in the chat or thinking about them. But before we open things up for that chat, I want to move over to Tina. And I'm fascinated, Tina, by your work on compassionate organizations. And wow, have we ever needed compassionate leadership over the last year? What have you been thinking about in the last year that you want to expand on?
Thanks, Jane. Totally. First of all, I want to acknowledge that my co-authors of the chapter, Rabia Khan, Irene Steliopoulos, Marion Briggs, and Sandra Fissman, the team brought together insights from a variety of levels and in the organization, from trainee to senior leadership to emergent leaders. And I think one point that we wanted to make very clear in our work for EMS and this book was that when we think about organizations, it's not just the sum part of the individuals within, but it's also thinking about the organization as a tool in and of itself for society. We conceptualize healthcare organizations as a type of complex technology. It's there to do a job for us. It's there to provide a service for society at whole. So our traditional way of thinking about an organization is problematized in the process. It's an organic tool that looks different based on the mandates of the day. It looks different because of the services we need to provide. And it looks different because societal priorities change. And that's a big theme throughout the book. When things change outside the clinic, we need to be adjusting. So what I'll focus on today is one dimension of compassionate organizations that we feel very strongly needs to be addressed. And one is the impact that an organization can have on the integrity of the individual healthcare providers to think of themselves as competent in the work that they do. And what do I mean by that? If we think about the organization as being a shelf for the people to do their work, they need to come to work in that shelf and be productive and feel productive. So when organizational leadership introduces new technology, introduces a new process, takes on a new mandate, they need to think about how is that going to impact the individual, all the individuals inside that organization. So change is not value neutral. And thinking about professional identities and how they intersect with the organization, we have to bring to the fore the ways in which we train, first of all. So we train health professionals to think of themselves as having a central professional identity, which is a combination of expertise, skills, but also a value system. So every time we introduce now a change into our healthcare organization, what we're doing is we're creating the conditions for identity dissonance. We're telling healthcare providers who may have spent over 15 years being socialized into practicing a particular way in order to show to be competent, to be there for their patients, that now the way they were doing it yesterday is no longer productive, and they have to reinvent themselves. And often they have to do that at a drop of a dime. We've all experienced this, right? So no technology, the smallest thing can actually create that identity dissonance in an organization. Of course, we pay attention to the organization-wide changes. When we were coming together to write this chapter, one of the things that I was studying in my work was at Sick Kids, the introduction of the new EMR, the electronic medical record. So I was tracking how that changed in relationship to a whole bunch of other broad organizational change agendas like caring safely and quality improvement initiatives were being embodied, first of all, whether or not they were being resisted, they were being embodied, and how they were being experienced by healthcare providers. And what was coming across was that there was a lot of frustration, not because people weren't paying attention to, issues of burnout and just the time that the rollout was needed. But sometimes the frustration was, people aren't realizing that this is actually changing how what it means to care. And have we had those conversations yet? Have we had that time? And I think we don't give ourselves that time, to be honest, to have those conversations. Sometimes we're not afforded the time. The pandemic didn't give us any time to roll out or pivot to virtual care and virtual training and virtual everything. But we need to be mindful that has an impact. So that relates to burnout. It relates to loss of empathy and erosion. What I described before as identity dissonance can be seen as the introduction of moral dilemmas, ongoing moral dilemmas. Overlay that, all our priorities right now to be equitable, to think about how the various intersections of our patients might impact their healthcare experience. And you have recipe for potential disaster if it's not taken into consideration in how one leads an organization. And it's not, sometimes it requires an appreciation from the top down, but also, grassroots coming together to renegotiate these value systems. But one thing that I was very, I'm going to use Sick Kids as an example. One thing that I was very impressed by very recently by our CEO was when Sick Kids had to pivot and start taking in adult patients or being open to referrals from across the province. That all of a sudden changed how the tool was being used, right, by the healthcare system. Well, that's a huge impact. Again, huge change in the tradition of what it meant to be working in Sick Kids as a hospital. And the compassionate response from our CEO to me was impressive in that there was a realization that some things now become less important. And there was a clear message that all non-important services, all non-important meetings, all non-important activities can be put to the side for a little while as we're adjusting, and think about taking care of yourself and your family. The other important piece that came across was that there was a recognition that we have some of our work happening at the front lines, but a lot of our work happening in the background or at home. And there was an equal attention to how burnout is being experienced by those at home as those at the front lines, and that their needs might be different. So that, again, makes you feel that you're not alone, which working from home, we all have experienced that sense of isolation, and that you have a leadership that's thinking about these things. And because they're thinking about them and talking about them, it allows you as a healthcare provider to raise your voice and say, you know what, something's not working here. Because how can you resist change that's there to make things better otherwise? You have to be given that space, that resisting change for progress is a good thing. And I'll end there and we can pick it up in the questions.
That is fascinating. And I love your example about the pivoting that took place at Sick Kids, which really was remarkable. But I imagine the identity dissonance that took place with people who had never had the experience of caring for people, adults in an ICU. It just, and people changing roles. We've seen a lot of that. It's been really quite remarkable. Well, we've already started getting some questions coming in, so I want to make sure that we attend to the questions from our audience, and I'll encourage others to go ahead and put things in the chat. So I'm going to start with one from Amy, because it's about medical education, and I think all of us here are really interested in education of health professionals. And she asks what each of you, what your thoughts are about how we need to position health scientists or healthcare education in the future based on, I guess, in part, what we've been through, but this whole issue of technology and compassion. How are we doing when it comes to education? Maybe I'll start with Brian.
Yeah, this week there's something really came to my attention, and it was a combination of two events. One was a really great discussion with a journalist writing a piece that's just out in Healthy Debate. Max Binks Collier asked me if I could put him in touch with some nurses that had to go through the challenge of having a dying patient talk to their family on an iPad. And I did find a couple folks who were willing to talk to him. And I realized, and the nurses who described this so poignantly talk about what that's like. And I think we're all experiencing some version of having to do things that we would never, ever have done over technology in the past. So there are new competencies. I think that we have to keep our competence frameworks alive. But it's also occurred to me in the last few weeks, it's become apparent that we've harmed our pipeline. It's a bad metaphor for graduate. I don't like to use manufacturing metaphors, but there is a continuous graduation of people, and we suspended almost all the clinical experiences for a year in so many places. And now we have shortages. We have nurses and physicians and RTs and perfusionists who we decided to protect from COVID. And although I think that was compassionate in one way, it was compassionate if we put ourselves in the shoes of the person, I think we did some harm to the competence of folks who are trying to come out. So I think, Jane, to your question, I would say what's top of my mind is we have to make a radical shift in our paradigm of competencies. Not a 15-year process. I think we need to make some pretty quick adjustments to our competence frameworks.
Well, we have certainly learned to try to do things quickly. So hopefully we are doing that as well when it comes to competency frameworks. Gillian or Tina, any other thoughts on how you're seeing this kind of shifting our way of educating health professionals?
Sure, I can jump in with, if I think about nursing education in particular. So a couple of years back, we started to see the integration of informatics and digital health competencies within the undergraduate or entry to practice level programs. And that is a great first step. And some schools decided to do so by having a focus, by having a specific course on, say, informatics or digital health, and others decided to infuse that throughout the curriculum. And I think perhaps as a first step, the standalone course made sense. But now as we think about how technology is really a part, and I say technology using the broadest definition that Brian described earlier, is really a part of what we do every day and has become an even greater emphasis of what we do every day, that it probably makes sense to have it infused throughout the curriculums now. Now, the challenge is, do we have folks that feel comfortable teaching that? And so I think that's something where that's going to be a tricky thing to resolve in the future, because the chicken and egg, how do you educate people if you don't have to be the leaders, if we don't have the folks that can be the educators in the first place and be those leaders in the first place. So that's one piece. The other thing is everything's happening so fast. Yeah. And so when it comes to compassion and thinking about this space, we actually have to think very critically and examine what we're doing, what's going well, what's not going well, and aim to understand it better than we do now. And so that we need to take a pause to do that well. And when is it appropriate to do that? That's a hard discussion to have. And I think that's when we bring in our ethics colleagues and colleagues from other disciplines to help us think that through.
Mm-hmm. I think for me, who has worked for the entire year from home, my entire repertoire of what it means to teach had to pivot. Like I used a lot of critical pedagogies and relational pedagogical approaches that require a lot of attention to classroom dynamics. And classroom dynamics are very fraught when we're relying on technology that's there to connect, but not necessarily to bring the cohorts together. So I've had sessions where we celebrated, oh my goodness, look, for this topic now we have 100 participants at this event. And before we used to attract for this particular topic 6 or 10 people. Yet the quality of that session, I actually have to wonder about, because it's not just reaching the individuals, it's being able to work with those individuals to create the transformations and the aha moments that we're expecting in the classroom. Why do I say this? Because some of the topics that I work with, and many of us in medical education, have to do with that social fabric that relates to how patients experience their healthcare. So that requires, again, going back and negotiating people's perspectives and helping see why equity, diversity, and inclusion is important right now, creating moments of reflexivity. But you can't do that unless you're watching people's reactions, and you can't intercept problems in the classroom. You can't see how they're impacting unless people are on Zoom. And I've had sessions where I've been teaching to a blank screen. And I do worry about that moving forward, because there is an efficiency that we're going to celebrate. And again, the outreach part of our work is, I think, very well served by these kind of technologies, but then there might be a potential loss if we're not careful. How reliant we become, as Gillian said, on certain platforms.
It's going to require a lot of rethinking for sure. And I'm sure all of the educators who are listening in are thinking about how we're trying to figure out how to take the best of what the last year has brought us, and not look forward to saying goodbye to the worst of it. But I just want to jump to another question, which I think is such a fascinating one, and I'm very eager to hear what you might say on this. It comes from Marnie, and she talks about social robots. And I mean, Gillian might be a good one to start off on this with a digital compassion perspective. She asks about whether social robots can become caregivers, and she's thinking particularly about people living with dementia or loneliness or memory loss. What's the role of robots, and are we going to see a day that we think of social robots being part of the health professional team? What do you think on that? I'll go to Gillian.
I think it's a fascinating question, and it's something that a colleague of mine at Western University and I have been thinking through and trying to buy some of these early versions and test them out in simulations. And so will they ever completely take over? I'll be honest, I don't think they're ever going to completely take over, but will there be opportunities to work with them in certain contexts? I think so. I think there'll be some, we already have in some of our care areas, the social robot cats. So I don't know if you've seen those. And so for some of our folks in our geriatric psychiatry program, that's been helpful. For others, not very helpful, right? So it's really dependent. And there's some really interesting new functionalities to some of these social robots, but can they completely replicate a human relationship? I'm not sure we're there yet. So I'll leave it at that.
You're a little skeptical, but maybe there's some room for a role. What do you think?
There's a role, I think.
I think they're already here. Siri is a robot, and so is Alexa.
Yeah.
So although having strong family history of dementia, definitely I think this tactile aspect, like the dementia seal, for example, I've seen that with elderly patients in some of the long-term care homes we were vaccinating, for example. I think there is something in the tactile and the presence. But to Gillian's point, it's like, is the voice responsive? Does it feel empathic? If you watch the movie Her, where the main character falls in love with his operating system, and because his Siri equivalent just says to him, I see you've canceled the gym every morning. Are you okay? I see you're not seeing your friends for dinner. Siri could do that today. And we've got chatbots in psychiatry already being used. So I think back to the principle, which is they'll be useful if they actually extend some genuine concept of compassion or empathy. if somebody's fobbed off on a robot because nobody has time to spend time with them, which is what we often do with dementia, that would be sad. That would be like, the phone that says to press 1 for this and press 2 for that, press 3 for the other thing, which is the least compassionate technology I could think of. But I think they're here.
Yeah.
Well, what would you say, Tina? Are you seeing robots replace?
I hope not replace completely. I think we're experiencing a little bit of being replaced by not being present. And not all of us are enjoying this. And I think that's something to consider. I don't want to keep dwelling on the negative because there's so much positives though afforded by all these futuristic technologies that we now have immediate access to. The fact that there is a Siri accessible to an average family, not all families, there's a lot of equity issues with regard to access to technology, but that can play a very sophisticated role in thinking about healthcare outside of the hospital or the clinic. Can there be a way to take, there's a lot of privacy and ethical issues, of course, but can we see technology being used in public health and health prevention? Can we see support? And we already see that with our watches and our Fitbits, et cetera, support for us to monitor our healthcare in a way that maybe reduces visits to a healthcare provider. But by reducing unnecessary visits, we might actually be increasing the capacity of the healthcare provider to invest the time in the visits that are required. So I think there's a lot of potential moving forward. Again, I'm always skeptical of, broad adoption without thinking about the unintended consequences. And I think if we are able to keep ourselves in check with some reflexivity and not get too overly excited, I think we pivoted quite quickly with COVID because we had to, but we can't afford not to go back and study the impact. I think there's an important role for science to support our medical training moving forward, including appreciating both the affordances and possibilities of technology, but also the dangers.
Well, that's really lends itself nicely to the thought of what we might lose, to the question that Gurinder puts in the chat, thinking about continuity of care. And I'm wondering whether the use of technology has had an impact on continuity of care. Of course, I'm a family doctor at heart, so continuity and longitudinal relationships are a big deal for family doctors and primary care providers. But what are your thoughts in terms of, the more we use technology, are we losing something in continuity? Have you noticed that in the last year? Have we lost anything? Anybody got his perspective on that?
I could try from my patients, Jane, a little bit as putting on my psychiatry hat. We went rapidly. Almost 100%. We were one of the services that was just shut down, basically. No in person and still no in person. So all my patients are still virtual. And it's interesting, your question. I think it depends a little bit on the individual. I also think it depends on how I'm trying to use it. I actually find a text can be empathic in the right circumstance. A text that just says, just checking in, how are you? Someone that I know has had suicidal ideation. That's pretty empathic, I think, for some people. On the other hand, I have to be honest, I have people that I know find my weekly Teams or phone call not as meaningful as sitting in the office where we can, there's that interpersonal thing. So for us in mental health, to Tina's point and Gillian's point, we really need time to study this. We've got to back up. Mental health went so rapidly into it, and we know that some of it's good. Some of it's definitely good. But I think there might be some there are some unintended consequences for our area.
Any other thoughts on continuity? Have you seen any changes in that, either Tina or Gillian? Any concerns?
I think one area that I've seen, and this is not with regards to, say, the large emphasis on, say, virtual care through a Zoom or through the phone that's really exploded in the last year, but with regards to seeing more patient portal type systems be present, or sometimes we refer to the concept of open notes, of being able to read some or all of the notes that healthcare providers have written about you. I think there's an opportunity there in terms of continuity of care from both patients having more ownership, potentially over their data, being able to share with caregivers and be able potentially to share with other members of the team that some of our functionality right now with our technology is limited, but in the future, being able to potentially share with your family physician, with other members of the team, which we've got to some degree through our Connecting Ontario, but not in the way that some of our patient portals and through this concept of open notes. Mm-hmm. One of the things I'm particularly interested in is with the concept of open notes, where if you read your note, is there a change in feeling of, say, compassion? Could there be a change in that relationship in some way? What about communication with the provider? What sort of these things that we've tended to not look at in the past as said softer? We've tended to look at, how have some of these technologies impacted some sort of clinical outcome? But what about the feeling of having that healthcare experience? How have these sorts of systems impacted that? And I think there's a continuity of care argument there.
Mm-hmm.
Could I just quickly add too that we've only talked about the communications, but I wanted to add the sensor technologies. This morning we were discharging a number of people from COVID ward, and they're not quite ready. They're going home. They have a home oxygen. They'll have a pulse oximeter. There's somebody watching their blood pressure and pulse and other things. That's enormously comforting for somebody who's frightened and maybe is home. And so in addition to just the compassion of the person and the have a call, is that somebody's watching, that there's a team. Now that can go too far into the surveillance. But to Gillian's point, if you know that you have a whole team, if you have a pharmacist and a doctor and a nurse and your psychiatrist and other people that are collectively there supporting you in the community, I do think that opens up possibilities for better care outside the big H if you're in the hospital, or outside the office if you're in the community.
Mm-hmm. I think pre-COVID, we were seeing a lot of that happening with reconceptualizing what it means to work in a team and team care, integrated healthcare clinics, overlapping scopes of practice that were not seen as problematic, but reinforcing. And what do I mean by that? Like, for example, the introduction of the EMR initially felt like a fragmenting technology because people were sort of distracted to now input on this new interface. And at first people were saying things like, well, I got my story in, like the nurse got their interview in, et cetera, but where's the synthesis happening? Mm-hmm. So as long as we don't forget that there has to be someone who synthesizes, someone who coordinates that sharing of information, et cetera. And the teams that responded quite well, I feel from other research now that I'm drawing that we've been observing, the teams that were considered high functioning, et cetera, were the ones that didn't just mechanically do the inputting as an accountability, but they were doing it as a way to information share and being able to access. And also this, now I'm going to draw on personal experience. What people were afraid of, that, writing on your notes and having your back turned to the patient really affects your relationship. Well, when my family physician invited me to actually be part of the writing into the chart, that was for me the beginning of a long history of eroding paternalistic care that made me a passive recipient of somebody else's gaze, and now put me in the gaze. Like, I was literally brought into analysis, like analyzing what was happening to me, where even changing words on the chart. Do you think this represents what you were saying earlier? I think we have so much possibility to rethink those relationships now with these new tools, right? So not to be afraid of them per se, but to be obviously cautious and to consider, our ethics or privacy principles and all that. But I think there's so much possibility afforded to us moving forward, especially to make the experience of healthcare not feel so fragmented for the patient.
That's a fantastic example, Tina. Talk about person-centered care, where you've got yourself in the driver's seat of care, which is great. It probably caused a little bit of identity dissonance with your provider to realize suddenly they were giving up the reins a little bit. But what a terrific example of compassion and technology hand in hand. I want to get to at least one more question because I think this is an important one. It's to someone who's asking about training. So people are really interested in how they can learn more. Deb is asking about, for both the providers, caregivers who want to become more compassionate in care, are there structured training programs that you might recommend? She asks specifically about one at Stanford called Compassionate Cultivation Training. Anybody got any training suggestions for those who feel a need to learn in this area? Where would you send them?
Gosh, what a great question. There's a lot of training emerging in the—
Read the book. Read the book.
Yeah, read the book. Yeah. There's a lot of technology. There's a lot of education emerging in the use of technologies. Some of it which shades into this. I know University of Toronto at the Michener Institute, we have, the application of digital technology. So compassion in that way. I'm just thinking about, wow, God, my colleagues. Like, where would you go? Compassion. Hold on. Let's back up. There's an excellent chapter in the book by the educator group, Spadoni, Rose, and Millette, who talk about the fact that education, the whole process of education, is wrapped up with compassion. So I would think for anybody that is in their undergraduate, it's not a separate course. It should be, as Gillian was talking about, infused all the way through. It should be at every single level. I would say if someone is already in training, they should have this conversation at the bedside, and they should have it in the clinic, and they should have it wherever they are. If you're talking about continuing education, yeah, I don't have a course that I can recommend right off the top of my head. I'm going to go away and see if maybe
you're going to go develop a course, aren't you, Brian?
I think I might just do that.
As you were asking, oh, sorry, Tina, go ahead.
I was going to say, I was just thinking about what's available across U of T. From the Center for Faculty Development and, a combination of collaborations across the system, the Summer Institute, which is introducing critical and transformative pedagogies, but with the purpose of helping healthcare providers and students become much more aware of how patients have various needs because of their interest, the various identities that they have in society. So the history of racism and structural and cultural imperatives to change, and bringing that kind of repertoire into how we practice those critical pedagogies and transformative learning frames help us, remind us to be reflexive. So I think that kind of teaching sort of brings in a compassionate, a side to compassionate care that we've been advocating for through AMS. AMS, of course, any AMS forum is a great place to learn.
You know what I'd love to see, Jane? The last 20, 30 years is all about being a simulation and practicing with simulated patients, standardized patients. Everybody's got these amazing units with these gifted educators and communicators. I think what we should do is, this question makes me think, we need to practice these, come into my office and communicate on Zoom, tell someone that their loved one is dying. Let's try that. Let's experiment in a safe space. Let's see if we can find ways to do it that really extend compassion. So, maybe we're not there yet. It sounds like a challenge.
Many opportunities. Gillian, you were going to jump in earlier there. Did you have a thought?
Sure. I have similar thoughts to Brian in the sense that we've got lots of education from the technology perspective. There are some courses that are specific to compassion, but where they infuse together, I think, seems to be the gap. And so I was thinking about a book that one of my co-authors that Dr. David Wilger would always refer to, and it was this handbook on compassion. I can't recall the authors or the full name of it, but I pictured this small little book. And when he brought out the handbook, it was this big textbook, quite thick book. So between this book, our book, in being sort of the first one to infuse it together and then starting to think through some of the basics of compassion, I think that's where you'd have to go for any materials. But I love your suggestion, Brian. I think in infusing this topic throughout any entry to practice level health professions program, it's got to be at the theory level, the practical level, embedded in practicums or clerkships or whatever it is for that particular health discipline. So you've got us thinking about what we need to do next.
Sounds good. Well, this has been worthwhile if it's got everybody thinking about next steps. So I think we can sneak in one or two more questions. Karen has a really great question here about efficiency. You know, we think about technology and tools as helping us to be more efficient, and she wonders about whether valuing efficiency promotes an over-reliance on things like virtual care, and whether it will keep doing that post-pandemic. And how do we kind of measure best care versus most efficient care in a resource-constrained environment? Anybody got thoughts as to how you make those measurements?
Tina, you look like you're about
I
to.
was going to say the first thing to do is not to silo conversations, which we have a tendency to do. So this notion of efficiency and how it feeds into healthcare productivity and outcome is something that quality improvement is very much concerned with, right? So efficient use of resources and also efficiency so patients don't wait endless hours in the waiting rooms are all, you know, incorporated into thinking about quality and improving the quality of the healthcare experience. But that conversation can be siloed if we're not bringing it into thinking about, well, is efficiency the same thing? And is it similarly important in education, and in what way? There is, of course, efficiency in learning to navigate all the different, differentials and finding like not having an endless conversation with a patient that never ends. Conversation meaning everything, including probing them and testing them, et cetera, until we figure out what's happening. We need to learn efficiency, right? So that part is also part of education. But are there ways in which we then sabotage ourselves, that efficiency becomes the goal and not we lose track of how to provide a caring experience? I think that's where that conversation can't be siloed. We can't be having conversations about how important it is to be empathic and being patient-centered without drawing together those other conversations that are also very important right now. How we use our resources and how we train.
You know, I wonder if we make a false dichotomy here. Like, definitely, I know sometimes the drive for efficiency, too many people to see, et cetera. But I'll give you an example. Like right after this call, my task today, as it has been all week, is I call all the families of all the patients I've seen on the COVID ward today and all week. And by doing that, you know, in my regular job, I get the complaints from the people that says, nobody's called me, I'm scared, I haven't heard anything. You're wasting like tons of time, not to mention the distress. A 2-minute call or a 5-minute call with everybody on my list is going to take me maybe half an hour, 45 minutes. So it feels to me like it's an efficiency measure because it's going to reduce a lot of other work and a lot of other worry. I think sometimes we get caught up into thinking, and psychiatry, you know, you got to have 45 minutes to talk to everybody. No, you don't. Our patient advocate, Judith John, always says, I don't need you to be your best friend. I just need you to look in my eyes and make contact and build a human relationship. That's an efficient use of communication.
Yeah.
I think we often create all this extra work because we don't take the time to have regular brief connections.
So on the first floor of the building that I'm in is our vaccine clinic. And so I've been doing clinical work there, vaccinating for the last several months. And I would say that to be efficient is to be compassionate to the long lineup of folks that we have outside of the gym, particularly on days where we have pop-up clinics. And so I love sort of the comments from Brian and Tina and saying not to dichotomize perhaps, and to think about how these things work together and fit together.
Excellent points. That's great. So we're going to run out of time, but there's been a fair bit of debate in the chat around, you know, virtual care is great. It's long overdue. And then, you know, virtual care is not going to ever meet our needs. What's the balance? Can we find that balance between these perspectives and here's another dichotomy for us: those who are enthusiastic adopters and those who are skeptical or anxious about the rapid what's that word I'm looking for? The rapid introduction.
Encroachment on our,
encroachment on our health systems of technology. Just a brief word of helping people on that balance. Any last thoughts?
Yeah, I feel that if we go back to the basic of technology, you could ask, are drugs good or bad? Are vaccines good or bad? Virtual, the phone is virtual. You know,
yeah.
would we be prepared to say that we should never use the telephone because it's not empathic? I think what we're reacting to, and going back to Tina's earlier point, and you know, some good social scientists need to understand the cutting edge technologies that we don't know how to use yet. So the Zooms and the Skypes and the ones where we're using video is what people are mostly referring to. I don't hear people criticizing the use of the telephone very much anymore. So one of the things that I think is going on is we don't know how to do it. We don't know how to do it competently. I don't know the difference between a really compassionate, excellent psychiatric hour on Zoom. I don't know. Sometimes I hate Zoom, sometimes I like it. I think what we're missing is a time to acclimatize, and back to Tina's earlier point about professional identity, it kind of freaks me out a bit to be a doctor on Zoom because I don't even know what that means. I do know how to be on the telephone. So I think it's not the technology. I think it's about the interaction of the technology with who we are and who our patients and families are.
And then if I may add, there is also a health systems, and our governments have a role in this as well, right? So when we made the pivot to virtual care, we also changed the way we pay for services. Before we couldn't, some of these services could not be charged, right? So let's think about that. That is also like those things are also part of why we decide to do things a particular way. Those are the structures that might not bend. You can get individuals to say, you know what, this is actually increasing my efficiency. I don't have to bring Tina into the clinic to tell her that her exam was fine. You know, I could call her up and tell her this, but then can I charge for that visit? Well, if I can't charge for 200 of those visits, what does that mean for my practice? I think those are important considerations, right? And that also affects decision making and how patients experience their care. So in some ways, I think this past year, being able to speak to my healthcare provider over Zoom and over the telephone has been emancipating. Because I didn't have to lose in other aspects of my life in order to make I have a family of 6 people. So you can imagine how many missed work days you would have in order to raise 3 kids and elderly parents who needed to go to healthcare because we had to physically always be present for everything. I think this is showing us a different way to think about our healthcare system.
That's great. Gillian, any last words of wisdom for us?
So I want to know what has worked well. So when is virtual care appropriate and when is it not? Because I think to some extent, we've all been guinea pigs in the last year or lab rats or whatever you want to refer to it as in trying to figure out how how do we triage what needs to actually be in person? And I'm not sure we figured that out. And so that's what I would like to see moving forward is more surety in that when we offer virtual care, that it's the right care to be offered.
Wonderful. Well, without compassion, there is no healthcare. So this has been a great conversation. And I want to let everyone who's been watching know that the event recording is going to be on the AMS website by Thursday at noon. So have a look for it there and share the link with people that you think might enjoy this conversation. And for those of you who are interested in purchasing the book, you'll also find a link there. And I think in the chat room, you should even see a link with a 20% discount. So go grab that now while you can. There is a free chapter for download on the AMS site. And that link will also be in the chat room now. So thank you to everyone for participating. And thank you in particular to our 3 exceptional authors who have shared their thoughts today. I've learned a lot, and I know that we'll all feel hopefully a little more compassionate and be able to stretch ourselves to make sure that we always have compassion in our care. So thank you very much. Merci beaucoup. Chi miigwech.
Thank you.